Okay. So, hi, evening, friends. Evening, everybody, bache. Evening, everybody. I guess we know each other pretty well. I'm Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemat-Oncology, AIMS Delhi. So, let's start with pathology. Now, before we even go further, I know Diwali ke baad this is our first session, and many of us are in that Diwali feel. It's our biggest festival, yaar. And last 3-4 days से हम लोगों ने पढ़ा भी नहीं होगा. So all of us are extremely fresh. Evening Aditi, evening Mitali, Ranju, Shilpa, everybody बचे. Evening Samira, Adya, everybody. So I know 3-4 दिनों से हम लोगों ने नहीं पढ़ा है. So it is actually nice that I'm personally glad that mine is the first class post Diwali. I'm saying so because गिल्टी फील से एक्चुअल पढ़ाई होती है. एंड टुडे वील बी स्टार्टिंग पैथोलॉजी एंड स्टडिंग अच्छे से. निमेश तो बहुत ही खुश है. निमेश के साथ आई नो निमेश ऑन अ पर्सनल लेवल ऑल्सो. एंड आई थिंक निमेश की लाइफ सेट होगी अभी. सो ही इज एक्सट्रीमली हैप्पी. अब देखो उसने मैसेज डिलीट कर दिया. Evening this, evening Drishti, Gautami, everybody. Just give me 1 second. I'm slightly getting more light on the face, and thoda sa adjust karke we'll be starting with our today's session. Just give me 1 sec. Just give me 1 sec, bache. ओके सो दृष्टि सॉरी तो बोलना ही नहीं है ना बच्चे. अगर मतलब द फर्स्ट टाइम वी आर इंटरेक्टिंग एंड इफ अ गर्ल स्टार्ट्स विद सॉरी तो मतलब हम लड़के लोगों की लाइफ में तो बिल्कुल शिटी हो जाता है. सो on this note, for everybody, I guess majority of us have joined, and we'll be doing lots of gossip. I have to tell you many things, but let us first 1.5 2 hours. We'll start with the content, and gradually we'll go forward. So for the new students, which I am Dr. Sushant Soni, MBBS MAMC, MD Pathology, Resident Hemat-Oncology, AIMS Delhi. And let's start. Let's start with our first session of pathology. Let's start with pathology. Now, pathology, bache, it is divided into 3 parts. That is general pathology. It is divided into actually 2 main parts. That is general pathology and hematology. General path and hemat. In hematology, we subdivide it into blood cancers. We subdivide it into oncohematology, that is blood cancers, and the non-oncology part, that is RBC disorders, bleeding disorders, RBC disorders, bleeding disorders, blood banking, and lastly is blood cancers. This was the hematology part. Versus, we'll first be starting with general pathology. And in general pathology, we'll be starting with our first easiest topic, that is cell injury. We'll be finishing it in our this session, followed by inflammation. We'll go to cell injury, inflammation, genetics, immunity, genetics, immunity, and neoplasia. This is our index. Frankly speaking, this is one of my favorite slides. I'm saying so because as the chapters keep on getting over, and you will yourself also feel it has a good feel to it. So let's start. Let's start with our first topic in general pathology, that is cell injury. Now, before I even go further, for majority of you know me, but even for the new students, we'll keep few basic rules in the class. That is, firstly, I'm the laziest person in class. So, bache, if I write something, you have to write it. Make your own set of notes because we have something called as a photographic memory. I know you will be having printed notes and everything with you. But if you write with your own handwriting, you will remember that we wrote it on the lower side, upper right hand side, and so on. For those of you who are revising or are viewing the lecture at 2x speed or something, in that case, you can highlight the notes. I'm totally okay with that. Secondly, in case you have any doubts whatsoever, please do not hesitate to ask me the questions. You can put the questions on the Telegram group and I'll be taking care of them. So let's start. Let's start with our first topic, that is cell injury. Let us start with cell injury. देखो बच्चे, normally cell is in a state of homeostasis. Normally, cell is in a state of homeostasis. Homeostasis means it's able to perform all its functions well. In case of an injurious stimulus, in case it receives an injurious stimulus, it tries to adapt itself. That is, it undergoes cellular adaptations. In case of an injurious stimulus, it tries to adapt itself. It undergoes cellular adaptations. There are four main cellular adaptations, which are hypertrophy, which are hypertrophy, hyperplasia, hypertrophy, hyperplasia, metaplasia, and atrophy. Metaplasia and atrophy. These are the four cellular adaptations. If the cell is able to adapt itself, fair enough. Otherwise, it undergoes cell injury. Cell injury, which it is of two types. It can either be reversible or irreversible cell injury. It is of two types, reversible or irreversible. Irreversible cell injury can occur by two patterns, that is necrosis. It can occur by two patterns, that is necrosis and apoptosis. These are all the terms which we will be discussing in our first topic, that is cell injury. So let us start. Let us start with our first category of cellular adaptations, that is hypertrophy. Let us start with hypertrophy. देखो बच्चे, the name tells you everything. Hypertrophy, rank 1, 2, 3. Everybody gets one trophy only. There is a difference in the size of the trophy. So hypertrophy, it is an increase in size of cells. It is an increase in size of cells. मान लिया, agreed. So it is a feature of dividing cells or non-dividing. It is an increase in size, not number. Number is not increasing. So it is seen in non-dividing cells. And predisposes to malignancy or does not predispose. For malignancy or cancer to occur, the cells need to divide. This is non-dividing. So this does not predispose to malignancy. Fair enough. Examples. देखो, before we go to examples, put a line on the side. We can divide cells into three types. Whenever we put a line on the side, it means we are writing the miscellaneous points. We can divide cells into three types. They can either be labile cells, stable, or permanent cells. Cells, बच्चे, they are of three types. Cells are of three types: labile, stable, and permanent cells. Labile cells, dividing, non-dividing? They are continuously dividing. Labile cells, बच्चे, they are continuously dividing in nature. Stable cells, I want you to comment on this. Stable cells, dividing, non-dividing? They divide. Stable cells, बच्चे, they divide under stress or injury. Versus permanent cells, which are non-dividing in nature. ठीक है, fair enough. Which are the examples of permanent cells? Which muscles? Muscles are of three types, na? Skeletal muscle, smooth muscle, cardiac. Which are permanent? Skeletal muscle and cardiac muscle. Skeletal muscle and cardiac muscle. Skeletal and cardiac muscle are permanent cells. Skeletal and cardiac are permanent cells versus smooth muscle. which is stable, versus smooth muscle, which is a stable cell. Smooth muscle is a stable cell. It is a stable cell. Next point. Which is the next example of permanent cells? That is neurons. Next example is neurons. Just give me one second. Next example of permanent cells being neurons. So cells were of three types. Just a second, guys. एक बार please check. Is it fine now? Let's come back and एक बार just drop me a yes. I love the yes वाला message to this that and actually I think the first person to say that was निमेश. बच्चे बताना होता है ना वॉइस इको हो रही है कोई भी प्रॉब्लम है बताना है ना. मेरी एक्स गर्लफ्रेंड की तरह एक्ट नहीं करना कि बताया ही नहीं एंड कि प्रॉब्लम हो रहा है एंड फिर बाद में गड़बड़. सो लेट्स स्टार्ट कमिंग बैक. So we saw that cells are of three types: labile, stable and permanent. I love the yes wale answer वैसे in everything in life. So cells are of three types: labile, stable and permanent cells. Labile cells, they are continuously dividing. Stable cells divide under stress or injury only versus permanent cells which are non-dividing in nature. So which are the examples of permanent cells? Cardiac muscle, skeletal muscle and neurons. देखो बच्चे, that is why in cases of MI, in cases of myocardial infarction, MI, cardiac muscle, it is permanent damage. In road traffic accidents, skeletal muscle damage, it is permanent. Neurons, of course, in cases of ischemic injuries to the brain, it is a permanent damage. Stable cells, they divide under stress. So in which parts of the body live organ transplant is possible? That is, you can give a part of that particular organ to your relative in case he or she is suffering from failure. Kidney, liver, pancreas. So stable cells, the examples are cells of kidney, liver and pancreas. Up to about 70% of liver can be donated, live organ transplant is possible. It divides under stress. Versus labile cells, the examples are bone marrow hematopoietic cells. All the cells of the bone marrow, the bone marrow hematopoietic cells, they continuously divide. They are labile. They divide continuously. All the epithelium, bache, they divide continuously. Examples of epithelium being stratified squamous epithelium of the skin, oral cavity, esophagus, columnar epithelium, GIT, transitional epithelium, kidney, urinary bladder. All epithelium, they divide continuously. ठीक है, मान लिया. So cells were labile, stable and permanent. So you tell me, this is the concept behind the hypertrophy. So you tell me which of these cells will undergo hypertrophy? Labile, stable, permanent. It is the permanent cells. It is the non-dividing cells which undergo hypertrophy. So if we have the concept behind it, the things to memorize will be much lesser. So which will be the examples of hypertrophy? Examples are cardiac adaptations. Examples of hypertrophy become cardiac adaptations in hypertension. If the patient's BP is very high, the cardiac muscle adapts itself. It undergoes hypertrophy so that it is able to pump blood against an increased BP. Cardiac adaptations. Next example is skeletal muscle. Next example of hypertrophy, which is skeletal muscle of bodybuilders. Agreed. These two were very basic, very obvious. What is asked is the lower two examples. Put a star, that is gravid uterus, pregnant uterus. Very, very important. Pregnant uterus. Which in pregnancy, it is combined hypertrophy and hyperplasia. It is combined hypertrophy and hyperplasia. Both the number and size of cells increase, but predominantly hypertrophy. Mainly it is an increase in size of cells. Predominantly hypertrophy. So pregnant uterus, it is combined hypertrophy and hyperplasia, but mainly it is an increase in size of cells. And the last example is breast. Again put a star. देखो बच्चे, we can divide a female cycle into 3 phases: puberty, pregnancy, lactation. In the first 2 phases, that is breast and puberty and pregnancy. In the first two phases, breast and puberty and pregnancy, it is combined hypertrophy and hyperplasia. Both the number and size of cells increase. It is combined hypertrophy and hyperplasia. Whereas by the third stage, that is breast and lactation, the number has increased sufficiently. It is only an increase in size of cells. It is hypertrophy only. These 3 points are very, very important, and this is what is asked. Please have a good look at this. Dekho, I'll repeat. We were studying hypertrophy. We saw that hypertrophy is an increase in size of cells. It is seen in non-dividing cells, does not lead to cancer. Examples were cardiac adaptations, cardiac muscle in hypertension, skeletal muscle of bodybuilders. That was obvious. Point to be remembered is gravid uterus is both hypertrophy, hyperplasia, mainly hypertrophy. Breast in puberty, pregnancy is both. Breast in lactation is hypertrophy only. First class. This was our first cellular adaptation, hypertrophy. Next, this gets us to our next cellular adaptation, that is hyperplasia. Which is this gets us to our next adaptation, that is hyperplasia. I need not even tell you this, that it is an increase in number of cells, obviously. So it is seen in dividing cells or non-dividing. I know majority of us, you are not able to reply to chat at this time and whatever. I 100% agree. But bache, commit to the answer before I speak it out. The recall will be much higher. So it is a feature of dividing cells. It is a feature of dividing cells. So leads to malignancy, it does not. Because it is a feature of dividing cells, this predisposes to malignancy. Comfortable. This was hyperplasia. Increase in number. Point is, we can divide hyperplasia into two types. That is physiological versus pathological hyperplasia. We can divide hyperplasia into two types. It is of two types: physiological versus pathological. The classical example of physiological hyperplasia is the normal menstrual cycle. The classical example is endometrium in normal menstrual cycle. Endometrium. You very well know from physiology as well as from basic anatomy that endometrium has proliferative phase, secretory phase, and the menstrual phase. The first two phases are hormone dependent, proliferative and secretory, and there is an increase in number. It is physiological in nature. Next example of physiological hyperplasia is hepatocyte regeneration. Next example is hepatocyte regeneration. Hepatocytes regenerate under stress. Liver was which cell? It was stable cell. It divides under stress. Hepatocyte regeneration, which is physiological in nature. Next example is bone marrow hematopoietic cells. You again know that all the cells in the bone marrow, they divide continuously. It is physiological hyperplasia. Fair enough. Versus pathological hyperplasia, the classical example of which is atypical endometrial hyperplasia. The classical example of which is atypical endometrial hyperplasia. It is excessive. It is atypical in nature. It is excessive in nature. As a result, this can lead to endometrial carcinoma. It was excessive in nature, so it can lead to endometrial carcinoma. It is pathological in nature. Next, Acha, I want you to tell me this. Suppose, bache, you have a history of a 56-year male presenting to OPD with painful micturition. He is having pain while urination, presenting to OPD with painful micturition with increased nocturnal frequency and increased risk of urinary tract infections. What is the diagnosis in this case? Obviously, this is a case of BPH. This is a case of benign prostatic hyperplasia. This is a case of BPH. BPH, that is benign prostatic hyperplasia. This is how you will be getting the questions in your paper also. There will always be 2 to 3 line classical history based questions. Why will an elderly male have painful micturition? Urethra passes through the prostate. If there is hyperplasia of the prostatic cells, they press upon the urethra, in turn leading to pain. If the elderly male is having pain, as a result of which it is associated with incomplete emptying of bladder. He is not emptying his bladder completely because he is having pain while micturition. As a result, there is increased frequency, which he is noting more at night. Daytime mein to he is okay going to the toilet again and again, but he needs to get up at night. So there is increased nocturnal frequency. Because urine was accumulating in the bladder, It is also increasing the risk of urinary tract infections. So this is BPH. Now see the question very carefully. In BPH, the prostate has undergone hyperplasia. But what about the smooth muscle of the urinary bladder? Please put a star to this. In BPH, there is prostatic hyperplasia. There is increase in number of cells of the prostate. But the smooth muscle of bladder, the smooth muscle of bladder, urinary bladder undergoes hypertrophy. So see the language of the question very carefully. The smooth muscle of the urinary bladder needs to contract. Or instead of smooth muscle, let me just write it as the muscle of the bladder. It undergoes hypertrophy because the bladder needs to contract. The bladder needs to contract against an increased pressure. So it has undergone hypertrophy. So this was our second cellular adaptation, that is hyperplasia. The first was hypertrophy. The next is hyperplasia. Next, but this gets us to our next cellular adaptation, that is metaplasia. Extremely important. If you get a question from cellular adaptations, the chances of question being asked from metaplasia are much higher. Hypertrophy and hyperplasia were plain and simple. Metaplasia, but this is one lining. Being replaced, one lining being replaced by another, that is metaplasia. One lining is being replaced by another. The classical example of which is Barrett's esophagus. The classical example of metaplasia is Barrett's esophagus, where the normal stratified squamous, of lower one third of esophagus, of esophagus is replaced by columnar. It is replaced by columnar plus goblet cells. You very well know that the normal lining of the whole of the esophagus is stratified squamous, non-keratinized. In Barrett's esophagus, the normal stratified squamous of the lower one third is replaced by columnar plus goblet. Why? The main risk factor of Barrett's esophagus being GERD, that is gastroesophageal reflux disease. There is gastroesophageal reflux leading to heartburn. To prevent heartburn, the body adapts. It's a cellular adaptation. It replaces the normal stratified squamous of lower one third with columnar plus goblet cells. Is it reversible or irreversible? Bache, metaplasia usually is reversible, but Barrett's esophagus in particular, put a star, is irreversible in nature. And is it good or is it bad for the patient? I mean, I'm very curious about it. It is a cellular adaptation. The body adapted itself, leading to reduced symptoms of heartburn. Is it good or bad? It is bad. Every short-term thing that gives us happiness is not good for us. It is bad. Why? Because it is pre-malignant. Pre-malignant means it can progress to cancer. It is pre-malignant for which carcinoma of the esophagus? There are two main cancers, squamous cell carcinoma and adenocarcinoma. Columnar cells in a bache. Wherever columnar cells are present, wherever glands are present, it can proceed to adenocarcinoma. It is pre-malignant. For adenocarcinoma esophagus, Barrett's esophagus. And again, Barrett's esophagus, answer. It is which metaplasia? Squamous metaplasia, columnar metaplasia, intestinal metaplasia, or cuboidal? The word before metaplasia is the end lining. This is an example of intestinal metaplasia. Please do not say it as columnar, because in Barrett's, along with columnar cells, it has goblet cells also. So the normal stratified squamous was changing to intestinal type. That is why it is called as intestinal metaplasia. This is Barrett's esophagus. And before we go further, let us have a look. Let us have a look at our first image. Let's have a look at the first image. Dekho, the minute I see this, we are clearly able to make out that this is the normal stratified squamous lining. This is the normal stratified squamous, which is changing to columnar plus goblet cells. These large white cells are the goblet cells. Acha, which stain is this? Everything is pink and blue now. This is the most commonly used stain in pathology, that is HND. It is hematoxylin. It is hematoxylin and eosin stain. Hematoxylin and eosin, HND stain. Hematoxylin, which it is blue in color and stains nucleus. So nucleus is blue versus eosin is pink and it stains the cytoplasm. Perfect, totally agreed. It is HND. Nucleus is blue, cytoplasm is pink. The minute you are able to see the presence of these large white cells, that is goblet cells, that means the normal stratified squamous is getting converted to columnar plus goblet. That is, it is a case of intestinal metaplasia, Barrett's esophagus. This is what Barrett's esophagus looks like microscopically. Grossly, dekho, you very well know that this is Barrett's. I need not even tell you that this is Barrett's. Grossly, which it has velvety red mucosa. Grossly, Barrett's esophagus shows velvety red mucosa. Now, girls know velvety red very well. For the guys, it has a fine texture to it. It has velvety red mucosa. This is Barrett's. Hence, I can safely divide metaplasia. Into two types. It can either be epithelial metaplasia. It can either be epithelial or connective tissue metaplasia. It can be epithelial or connective tissue metaplasia. Which is more common? Epithelial. More common epithelial. Epithelial metaplasia can further be divided into two types. It can either be squamous. Make this flowchart comfortably. We will not write much below connective tissue. It can either be squamous or intestinal metaplasia. You very well know that intestinal metaplasia, the classical example is Barrett's esophagus. You know that. Which is more common? Squamous or intestinal type? Which is more common? Squamous. Squamous metaplasia is again more common. Squamous metaplasia means normal lining is changing to squamous or squamous to something else? Normal is changing to squamous because the word before metaplasia is the end lining. Normal lining is changing to squamous, that is squamous metaplasia. And the most common site of squamous metaplasia being respiratory tract. Most common site being the respiratory tract. Where? What is the normal lining of the respiratory tract? Pseudostratified ciliated columnar. Where? Bache, the normal pseudostratified ciliated columnar. Normal pseudostratified ciliated columnar is changing to squamous. The main risk factor being smoking. I usually say this at this point. Dekho, I do all morally bad things in life, but smoking is something I'm very much against, which it's actually injurious to health. I mean, as a faculty, as having alcohol also is injurious, but as a senior and friend, it's okay to have it. Clear this stupid paper and hum nadiyan baha denge, no doubt about it. But smoking is actually injurious to health. You will be seeing it in medicine that it is associated with the worst type of lung cancer. SM smoking na, SM which lung cancer? Small cell carcinoma. Worst prognostic, lung cancer, small cell carcinoma. So even if do not smoke, I mean, absolutely no doubt, combining alcohol with smoking is disastrous. Even if one of you stop smoking today, I'll consider the lecture as a success, and I always say it at this point. So respiratory tract, the main risk factor for squamous metaplasia is smoking. And which vitamin deficiency leads to the lining becoming squamous? Vitamin A deficiency. Vitamin A deficiency. Agreed. So squamous metaplasia, which is the most common example, the most common site being respiratory tract. The next example of squamous metaplasia is endocervix. The next example is endocervix. Endocervix. Again, you know that the normal columnar lining of endocervix, normal columnar, changes to squamous. Why? Main risk factor being, I'll wait for you to commit to this answer, especially guys. Which famous personality died of cervical cancer recently? Famous young personality. PP, Poonam Pandey, I know. So, frankly, I was pretty saddened by her death. But after 2 days, we came to know that no, it was a cervical cancer awareness campaign from her side. So, after knowing that she is alive, were you slightly angry? But not important. My question to you is, what was she generating awareness about, firstly? And secondly, what changed? Something major changed. What changed that she got up one fine day and thought, ki, let me generate awareness? She was generating awareness about HPV. Agreed. What changed, बच्चे? नेम द हाई रिस्क एचपीवी. पहले तो हाई रिस्क एचपीवी बता दो. एंड तुम पूनम तो देखो ऐसे लिख रहे हो जैसे हमारी बेस्ट फ्रेंड है. पांडे भी साथ में लिख लेते हैं. High risk HPV, the main high risk HPV being HPV 16 and 18. Agreed. So endocervix, main risk factor being HPV. Government of India has introduced HPV vaccination free of cost for all school going girls aged 9 to 14 years in the national immunization program. So chances of you getting a question on HPV are extremely high. We'll be doing this in detail. So HPV, endocervix. Next, the next example of squamous metaplasia are the ducts of lacrimal and salivary glands. All the ducts of lacrimal and salivary glands, breast and pancreas. All the ducts. What is the normal lining of the ducts? Cuboidal. The normal cuboidal changes to squamous. Again, the main risk factors being smoking. And the presence of stones along with vitamin A deficiency. Stones and vitamin A deficiency. I am not much concerned about squamous metaplasia in the ducts of these organs, but squamous metaplasia of the respiratory tract and cervix was important. That was squamous metaplasia. So epithelial metaplasia was of two types, squamous and intestinal. Intestinal is Barrett's esophagus. We have done that. This was epithelial. Versus the other side, that is connective tissue metaplasia. The classical example of which is myositis ossificans. That is bone formation in muscle. Ossificans, bone formation in muscle because of trauma. This is metaplasia. And lastly, Acha, before we go further, again you tell me the answer to this. What do we see here? Dekho, left hand side, the minute I see this, I am able to make out that this is normal brain. I am comfortable with that fact. Brain, which it shows the presence of gyri. The elevations are the gyri, the depressions are the sulci. This is a nice normal brain. This is normal. Versus the second image, where there is widening of sulci. The sulci have widened. There is widening of sulci with narrowing of gyri. The depressions are wide with narrow gyri, making this as a case of cerebral atrophy. Which is the most common cause of cerebral atrophy or most common cause of dementia in elderly? That is Alzheimer's disease. Most common cause of dementia in elderly being Alzheimer's disease. So this was a case of cerebral atrophy. As a result, which this gets us to a last cellular adaptation, that is atrophy. This gets us to atrophy. I need not even tell you that atrophy, it is reduction in number and size of cells. Atrophy, it is reduction in number and size. ठीक है, मान लिया. We can divide atrophy into two types. It can either be physiological. It can be physiological versus pathological atrophy. Atrophy, but it is of two types. It can either be physiological or pathological. It is physiological versus pathological atrophy. Which is the classical example of physiological atrophy? All of us have undergone physiological atrophy. I know we guys, the first organ that usually comes to our mind is breast, but no, let's not jump to breast. So you are right about breast and uterus post-menopause. So physiological atrophy. The classical example of physiological atrophy is during embryogenesis. During embryogenesis, many structures form and involute. The classical examples being notochord. When we were embryos, all of us had a tail. Unfortunately, now we don't. Notochord and thyroglossal duct. So during embryogenesis, many structures undergo physiological atrophy. Next example of physiological atrophy is thymus at puberty. Next example is thymus at puberty. And lastly, breast and uterus. And lastly, breast and uterus post-menopause. These are physiological in nature. Versus, so whenever you are studying anything, our target is not to increase our knowledge. Okay, fair enough. Obviously, knowledge to badi rahi hai, but when you are taking classes with us, the main target is to ensure that you clear paper with an extremely good rank. So, bache, whenever you are studying theory, think of it as if the question comes in the paper, whether I will be able to mark it right or not. If any of these examples are given to you, you will be very sure that it is physiological in nature. During embryogenesis, many structures form and involute. Breast and uterus post-menopause, thymus at puberty, this is all physiological. Versus pathological atrophy. Only the first point needs to be noted, that is senile atrophy. Please note that senile atrophy is pathological in nature. It is associated with aging, but which is the most common cause of dementia in elderly? Alzheimer's disease. But it is pathological in nature. It is a disease, it's not a physiological process. Alzheimer's. Next example of pathological atrophy is disuse atrophy. Next example of pathological being disuse atrophy. What did we not use that it led to atrophy? No double meanings, but what do we mean by disuse atrophy? What did we not use? Skeletal muscle. Disuse atrophy of the skeletal muscle because of chronic immobilization. Disuse atrophy of skeletal muscle because of chronic immobilization. The patient is chronically immobilized. He has had severe paralysis. He is bedridden for some other injury or any disease or something. So we call a physiotherapist to move his limbs. Otherwise, the skeletal muscle will undergo disuse atrophy. It is pathological in nature. The next example of pathological atrophy is pressure atrophy. Next example is pressure atrophy. What caused pressure? tumor, benign या malignant? Benign tumors. देखो बच्चे, benign tumors, they are well encapsulated, they grow locally, they do not infiltrate, do not metastasize, versus malignancies which tend to infiltrate and metastasize. So pressure atrophy by benign tumors compressing nerve and blood supply. Pressure atrophy is by benign tumors which compressing nerve and blood supply of affected organ. Compressing nerve and blood supply. Pressure atrophy. Next example of pathological atrophy. It is seen during fractures. Pathological atrophy, which it is seen during fractures and protein energy malnutrition. Fractures or protein energy malnutrition, that also leads to atrophy. Reduced nutrition, so the patient is extremely thin and atrophied. That is pathological atrophy. And lastly is denervation atrophy. Lastly is denervation atrophy. Denervation atrophy means the nerve supply has been cut. Denervation atrophy. Nerve supply क्यों कटी? Why is the nerve supply being cut? Because of surgery or trauma. It can occur because of surgery or trauma. So these are the cellular adaptations. This was atrophy, physiological versus pathological, and these are the cellular adaptations. So there were 4 main cellular adaptations, which are hypertrophy, which is increase in size of cells. Hyperplasia, which is an increase in number of cells. Metaplasia extremely important. Epithelial versus connective tissue metaplasia. Epithelial में squamous metaplasia is more common, the main site being respiratory tract. In the respiratory tract, which everybody is comfortable with smoking, that is the main risk factor being smoking. And which vitamin deficiency? Vitamin A deficiency. देखो, whenever vitamin A is deficient, it leads to formation of squamous lining. Same thing we saw with respect to ducts also. All the ducts of the glands, they have normal cuboidal lining. In cases of stones and vitamin A deficiency, the normal cuboidal becomes squamous in nature. It becomes squamous. So vitamin A deficiency predisposes to development of squamous metaplasia. This was metaplasia. Squamous versus intestinal type, that is Barrett's. The other side was connective tissue. This is what Barrett's esophagus looked like. And the last cellular adaptation being atrophy. Most common cause of dementia in elderly being Alzheimer's disease, which is pathological atrophy. We divided atrophy into physiological. Versus pathological. These are the examples of pathological atrophy. First class. So these were cellular adaptations. Everybody, please give me a thumbs up or feel comfortable or something. Drop me a message if all of you are comfortable with all the points that we have covered till now. Next. So these were the cellular adaptations. If the cell is able to adapt itself, I'm waiting for a thumbs up at this point. No doubt about this. So, and Shilpa actually beautifully said that many people actually got vaccinated after her only. No doubt. So, coming back, these were the cellular adaptations. If the cell is able to adapt, fair enough. Otherwise, it undergoes cell injury. Okay, so this starts us. Let me change the page. Okay, so bache, this starts us with our next topic, that is biochemical mechanisms. This starts us with biochemical mechanisms of cell injury. First point. Acha, before I even enter into the biochemical mechanisms of cell injury, that is, or let me rephrase this as most common cause of cell injury being ischemia. Ischemia, that is reduced blood supply. Ischemia means reduced blood supply, which leads to hypoxia. Which leads to hypoxia. Hypoxia, which is reduced oxygen. See, there can be many causes of cell injury. It can be ischemia, that is reduced blood supply, toxins, chemical injury, physical damage, infections, radiation damage. There can be many causes of cell injury. The most common cause of cell injury being ischemia, that is reduced blood supply, which leads to hypoxia. So which is worse? Ischemia or hypoxia? Which is worse? Ischemia. Ischemia, because this is reduced blood supply. So along with reduced oxygen, it has reduced nutrients also. Ischemia leads to hypoxia. So ischemia is worse. Next point. When there is reduced blood supply, which is the first organelle affected in cell injury? Which is the first organelle affected? Mitochondria. Whenever there is reduced blood supply, the first organelle affected being mitochondria. So I can safely say that the first biochemical feature. So I can safely say that the first biochemical feature of cell injury being, what is the job of mitochondria in the cell? It is the powerhouse of the cell. It synthesizes ATP. So the first biochemical feature being reduced ATP, which occurs within seconds. First biochemical feature being reduced ATP. ATP is needed for all the functions in the body. Reduced ATP leads to reduced action of sodium potassium ATPase pump. Reduced ATP, which it causes reduced sodium potassium ATPase pump. Again, you know very well from physiology that where is sodium more? Intracellularly, extracellularly? Intracellularly. Sodium is more intracellularly, potassium is more. My mistake. I said it the other way around. I think I was slightly distracted. So potassium is more intracellularly, sodium is more extracellularly. This is normal. This imbalance is maintained by sodium potassium ATPase pump. If there is reduced action of sodium potassium ATPase, there is influx of sodium and water. Sodium and water comes inside, and efflux of potassium. So again I can say that the first microscopic feature of cell injury being influx of water, that is cellular swelling. First microscopic feature of cell injury being cellular swelling. देखो बच्चे, again I am saying this, nothing is to be rectified. If you understand the concept well, pathology becomes extremely easy and simple. So first organelle affected mitochondria, first biochemical feature reduced ATP, first microscopic feature cellular swelling. These are the first mistakes now. So guys, at least that is what we expect. I'll not ask girls this question क्योंकि आजकल तो पहली गलती भी माफ नहीं होती. But coming back, these are the first mistakes. So these are reversible in nature. Reduced ATP occurring within seconds, cellular swelling. These are reversible features of cell injury. We'll come to reversible versus irreversible. Very important. Next point. In cell injury, cytoplasmic calcium increases. Recent NEET PG MDS PYQ. So please put a star. Cytoplasmic calcium increases. There is increased calcium in the cytoplasm of the cell, which in turn leads to activation of numerous enzymes, like ATPases, which reduce ATP. Phospholipases, which causes membrane damage because the cell membrane is made up of phospholipid bilayer. Phospholipases causes membrane damage. And endonucleases, which causes DNA damage. Endonucleases which cause DNA damage. So cytoplasmic calcium increases, which in turn leads to activation of numerous enzymes like ATPases, phospholipases and endonucleases. Okay. These are the biochemical mechanisms of cell injury. Fair enough. First organelle affected mitochondria, biochemical feature reduced ATP, microscopic feature cellular swelling, cytoplasmic calcium also increases. So this gets us to reversible versus irreversible cell injury. Let us first start with reversible cell injury. You already know, I want you to tell me, you already know the first microscopic feature of reversible cell injury being influx of water, that is cellular swelling. First microscopic feature, you know this, is cellular swelling. This in turn leads to, देखो बच्चे, suppose that this is the plasma membrane of the cell with microvilli. This is the plasma membrane with microvilli. If there is influx of water, it is associated with the bleb formation. Cytoplasm ऊपर की तरफ उठ जाएगा ना, water has entered into the cell, so cytoplasm will get blebbed. So it is associated with blebbing, blunting and loss of microvilli. Microvilli were sharp. Cytoplasm got elevated, so it got blunted. Blebbing, blunting and loss of microvilli. Next point, because of influx of water, it is also associated with swelling of endoplasmic reticulum. It is also associated with swelling of endoplasmic reticulum and detachment of polysomes. Swelling of endoplasmic reticulum and detachment of polysomes. कुछ भी नहीं था. All these points were the same, that is, it is associated with influx of water or cellular swelling. All these points were the same. Point to be noted here is, it is also associated with accumulation of. It is associated with accumulation of small amorphous densities. Accumulation of small amorphous densities in mitochondria. Accumulation of small amorphous densities in mitochondria. The main word in this line being small, which is very, very important. First organelle affected in cell injury was mitochondria. That forms the break point. Presence of amorphous densities in mitochondria. If it is a small amorphous density, it is reversible cell injury. If it is a large amorphous density, it is irreversible cell injury. Small है तो reversible, large amorphous density है तो irreversible. So बच्चे, you tell me, small or large is not written. Only amorphous densities in mitochondria is written. What will you mark? Reversible cell injury or irreversible? What will you mark? Reversible or irreversible? If nothing was written, only amorphous density is written, it can be large also, na? So if that is irreversible cell injury. So if small is written, reversible, large or nothing is written, irreversible cell injury. So these are the features of reversible, and this gets us to the other side, that is irreversible cell injury. This gets us to the other side, that is irreversible cell injury. Irreversible cell injury. Irreversible. You already know which is the first microscopic feature, or which is the first feature of irreversible cell injury. It is the presence of amorphous flocculent densities. It is the presence of amorphous flocculent densities in mitochondria. Now I did not write large. Like you guys were very, very right. If it is small, reversible, large or nothing is written, irreversible. Amorphous flocculant densities in mitochondria, which is detected by, how do we detect? How do we detect mitochondria? Or how do we visualize mitochondria? By electron microscopy, which is detected by electron microscopy. Obviously, I'm able to visualize the cell by light microscopy. Mitochondria is visualized by electron microscopy. So first feature is amorphous flocculant densities in mitochondria. Next point, irreversible cell injury, which is next are the nuclear changes. Next are the nuclear changes. There are three main nuclear changes. That is pycnosis, karyorrhexis, nuclear changes. That is pycnosis, karyorrhexis, and karyolysis. There are three changes. Pycnosis is chromatin condensation. Chromatin condenses, the nucleus condenses. Pycnosis, which is, this is chromatin condensation. Karyorrhexis, fragmentation of the nucleus. In pycnosis, the nucleus condensed, chromatin condensed, then it got fragmented. Karyorrhexis, that is fragmentation of the nucleus. And lastly is karyolysis, that is dissolution of nucleus. Karyolysis, that is dissolution of the nucleus dissolves. Obviously, when there is so much damage taking place to the nucleus, it is irreversible. Pycnosis, it condensed, fragmented, karyorrhexis, and dissolved, karyolysis. So again, you tell me, basophilia. In irreversible cell injury, basophilia reduces or increases? What was blue in a cell? Nucleus is blue, cytoplasm is pink. Nucleus condensed, fragmented, and dissolved. So basophilia reduces. Nucleus तो गायब हो गया ना, basophilia reduces. Eosinophilia increases. This was reversible versus irreversible cell injury. So till now we saw that cell injury, whenever cell is usually in a state of homeostasis, in case of an injurious stimulus, it tries to adapt itself. It undergoes cellular adaptations. There was 4 cellular adaptations: hypertrophy, hyperplasia, metaplasia, atrophy. If it is able to adapt, fair enough, otherwise it undergoes cell injury. Cell injury was of 2 types, reversible and irreversible. Irreversible cell injury, which it can occur by 2 patterns. That is necrosis versus apoptosis. Irreversible cell injury, it occurs by 2 patterns. That is necrosis versus apoptosis. Let us have a look at the master table, and then we'll start with patterns of necrosis in our next session. Let's have a look at the master table in this. Necrosis, programmed है कि non-programmed? Non-programmed. Necrosis, which it is non-programmed cell death. It is non-programmed. It just happened because of infection, ischemia, or so on. So it is only pathological in nature. It is non-programmed cell death, and it is only pathological. Versus apoptosis, of course, which I am sure you know also, that it is programmed. Which proteins play a role in apoptosis? Caspases. It is programmed caspase dependent. Caspase dependent cell death. Which proteins play a role in apoptosis? Caspases. So it is caspase dependent cell death. It is both physiological and pathological. Physiological apoptosis example being, the classical example is during embryogenesis. Notochord, thyroglossal duct, so many structures form and involute. That is it, they undergo physiological apoptosis. मान लिया, agreed. Point to be noted here is apoptosis, which it is not associated with inflammation. Inflammation is not seen. It is not seen in apoptosis. So I can safely say that leakage of cellular contents. So leakage of cellular contents occur or do not occur? They do not occur. They do not occur. So plasma membrane integrity. देखो बच्चे, these 3 points are the same. There is no difference. Plasma membrane integrity is maintained or lost? Plasma membrane integrity is maintained. देखो, these 3 points are the same. Plasma membrane integrity is maintained. So leakage of cellular contents does not occur. अगर plasma membrane integrity maintained है तो cell content कैसे leak होंगे ना? Leakage of cellular contents does not occur and it is not associated with inflammation. Versus necrosis, which is associated with inflammation. So leakage of cellular contents is seen and plasma membrane integrity is lost. Very, very important. Next, again put a star. Apoptosis, but it is not associated with cellular swelling. It is not associated with cellular swelling. Recent NEET PG PYQ MBBS segment. Simple, straightforward MBBS segment PYQs are asked in our MDS exam. So important hai. Apoptosis, it is not associated with cellular swelling. This was the master table. This was the master table of necrosis versus apoptosis. So irreversible cell injury, it can occur by 2 patterns, necrosis and apoptosis. This is the master table of the same. Now, before we go further, let us have a very small 5-minute break at this point. It's not the lambe wala break, of course. We'll have a slightly longer break at about 7:20, I guess. I want to finish the patterns of necrosis with you along with the images. And then we'll take a break around 7:20. We'll munch on something and stuff. So right now, to just let's take a round around it. How many of you are writing stuff? I mean, I'm very, very curious. Today, though, we are studying after 4 days, yaar. तो अपना क्या condition है? We are sitting on the table very guilty. The first option is feeling very, very guilty. He had lots of fun, did crazy stuff and like Nimesh and all. Nimesh तो बहुत ही खुश है आज. चिंचू भी ठीक है. So, and we are writing. This is the first option. Second option is कि नहीं ठीक है, इतना कुछ मचाया नहीं. We already have the handwritten notes. So I'm sitting on the table, but notes are with me. I'm not writing. These are my hands. Third option is lying down on the bed, listening and highlighting the notes. Fourth option कि नहीं, everything is in the cloud. Very, very curious. Very curious. Everybody. Abhi today to is day 1 and my target is बच्चे day 1 to 3. We will study with full concentration. We will finish majority of the content. हाँ, right now तो we guys are writing. पहली चीज. Plus secondly यार, I was so happy on that message. मिताली लिख नहीं रही, वो तो चलो ठीक है मिताली, तुम I know you. So नहीं, शिल्पा मिताली is a very close friend and I know her, तो उसका चलेगा. चिंचू पता नहीं क्यों सेकंड वन पे क्यों, वो पहले अटेंड कर चुकी. आद्या वैसे आई हैड टू चैट विद यू ऑल्सो बिकॉज हम सब लोगों की लाइफ में तो गन मचा हुआ है. आई थिंक आद्या इज द ओनली वन हु इज द हैप्पीएस्ट इन अ रिलेशनशिप. मतलब सीरियसली व्हेन आई रोट अबाउट दैट कि लेट्स डिटॉक्सिफाई दिस दिवाली, मेजॉरिटी ऑफ अस नीडेड डिटॉक्सिफिकेशन. बट एनीवेज विल टॉक अबाउट दैट लेटर. इतने सारे लोग सेकंड ऑप्शन पे क्यों बैठे हैं? दृष्टि, सौरभ, समीरा, We have attended पहले. अच्छा चलो कोई बात नहीं. Agreed. Agreed. So let's have a small 4-5 minute break at this point for the fresh students. अच्छा नो हिंदी. तुम तो निमेश मेरा मुंह मत ही खुलवाओ. हाँ चिंचू नो हिंदी यार. Fair enough. I just know academic content in English. See, I am from a village. I did my schooling in a village close to Delhi till class 8. So I think in Hindi, translated in English. अगर मैं PJs, if I start saying PJs in English ना तो चलेगा नहीं. But ठीक है, all academic content in English. So see you all in 3-4 minutes, and then we start. Then we start with our first pattern of irreversible cell injury, that is necrosis. Mithali agreed. Adya, उसको फ्रेंड्स विद बेनिफिट कहते हैं. हैप्पी एंड सिंगल कुछ नहीं होता. ये एटलीस्ट लड़कों में तो नहीं होता. दैट इज व्हाट आई फील. But coming back, see you all in 3-4 minutes. We'll pull her leg later. See us. Okay, okay. So, bache, come back. I just wanted to finish necrosis also in this session, and then we take a nice good break. So let's start. Let's start with the same link. Everything is the same. I'll just give 1 second for everybody to come in, and then we'll start. हाँ बच्चे BA. BA, this is wrong. So, okay. So let's start. Let's start. We saw that irreversible cell injury occurred by two patterns: necrosis versus apoptosis. Let us have a look at our first pattern of irreversible cell injury, that is necrosis. You already know it is non-programmed cell death. It is associated with inflammation. Leakage of cellular contents is seen. Plasma membrane integrity is lost. It was associated with cellular swelling, and it was only pathological in nature. You know these points with necrosis. So this starts us with patterns of necrosis. Starting with, which was the most common cause of cell injury? Ischemia. So ischemia of any organ of the body is associated with coagulative necrosis. Let us start with patterns of necrosis. The first is coagulative necrosis. Coagulative necrosis, which is the most common pattern of necrosis. Coagulative. It is the most common pattern of necrosis, which is associated with ischemia. It is associated with ischemia of organs. Ischemia of any organ of the body. Ischemia of any organ of the body is coagulative necrosis, except ischemia of the brain, except ischemia of CNS, which is associated with liquefactive necrosis. We'll see that when we study liquefactive necrosis. So most common pattern of necrosis is coagulative necrosis. It is associated with ischemia of any organ of the body except brain, that is liquefactive. Next point. When ischemia of organ is taking place, when ischemia of any organ is taking place, what happens is that the cell boundary is intact, but there is necrosis inside it. So microscopically, it has the classical tombstone appearance of the cells. Microscopically, it has the classical tombstone appearance. We are comfortable with what is a tombstone. Tombstone is there's stone outside with dead body inside it. No? Same thing is true here, that the cell boundary is intact with necrosis inside the cell. That is tombstone appearance of the cells. Coagulative necrosis. But there is a special subtype of coagulative necrosis called as Zenker's degeneration. There is a special subtype. There is a special subtype of coagulative necrosis called as Zenker's degeneration. Zenker's degeneration. This is a special subtype of coagulative necrosis only. We are studying it under coagulative only. It is a special subtype of coagulative necrosis associated with typhoid infections. And it causes necrosis of which muscle? Skeletal muscle followed by cardiac. It is associated with necrosis of skeletal muscle. Skeletal muscle kahan ki? Skeletal muscle of where? Of the abdomen. It is associated with necrosis of skeletal muscle of the abdomen, followed by cardiac muscle. Which is the skeletal muscle of the abdomen? Guys, those of you who are into exercise and six-pack and all, which is the skeletal muscle of the abdomen? Rectus sheath and diaphragm. So it is associated with necrosis of skeletal muscle of the abdomen, that is rectus sheath and diaphragm, followed by a cardiac muscle. Fair enough, it was Zenker's degeneration. It was a special subtype of coagulative necrosis. Next, the next subtype, the next pattern of necrosis is liquefactive necrosis. So first is coagulative necrosis, next is liquefactive necrosis. Liquefactive necrosis, which this is associated with infections. Liquefactive necrosis is associated with bacterial or fungal infections. It is associated with bacterial or fungal infections. You already know it is also associated with ischemia of CNS, ischemia of the brain. Liquefactive. It obviously, if infections are taking place, bacterial or fungal infections is taking place, it is associated with pus formation. That is, leads to liquid viscous mass or pus formation. So cell integrity is lost. As a result, cell integrity is lost. Cell integrity is maintained in coagulative necrosis. That was why it had tombstone appearance. Versus liquefactive necrosis, where cell integrity is lost. Next, we'll have a look at all the images together. Absolutely not to worry. Next, but the next pattern of necrosis is caseous necrosis. Caseous necrosis. I need not even tell you that caseous necrosis. It is associated with formation of cheesy white material in the lungs. I'm sure all of us are comfortable with this fact that it is associated with formation of cheesy white material in the lungs. Caseous necrosis with granulomas, seen in TB, tuberculosis, and fungal infections. Which fungal infection? That is, it is associated with histoplasmosis. So, as you told me, very right, everybody is comfortable with the fact that it is associated with TB. Along with TB, it is also associated with fungal infections, that is histoplasmosis, caseous necrosis. Next, the next pattern of necrosis is gangrene. The next pattern of necrosis is gangrene, which it is a non-specific clinical pattern of necrosis. It is a non-specific clinical pattern. That is, the clinician, he just went to the ward and saw that necrosis has occurred. Gangrene has taken place. So gangrene, it can be of two types. It is dry gangrene, that is, no pus is forming. Dry gangrene, which is a type of coagulative necrosis, versus wet gangrene. It is wet because it is associated with pus formation, which is a type of liquefactive necrosis. Dry gangrene versus wet gangrene. Dry gangrene is coagulative necrosis, wet gangrene is liquefactive. So you tell me, what will be diabetic foot? Recent NEET PG PYQ segment. What will be diabetic foot? Dry gangrene or wet gangrene? Diabetic foot, I am sure that when you would have gone to surgery postings and all, you would have seen that the distal part of the foot or the toe has undergone necrosis because of atherosclerosis. But diabetes predisposes the patient to infections because of high sugar. Increased sugar, increased risk of infections. That is, it is associated with pus formation. It is wet gangrene. Diabetic foot, bang on right, but it is wet gangrene because it is associated with pus formation and increased risk of infections. Agreed. Next, the next pattern of necrosis is fat necrosis. Fat necrosis. This is associated with chronic pancreatitis. It is associated with chronic pancreatitis. Which is the most common cause of chronic pancreatitis? Chronic alcoholism or long-term alcohol intake is the most common cause of chronic pancreatitis. It is associated with chronic pancreatitis, which leads to enzymatic digestion of fat. Fat necrosis, chronic pancreatitis, which it leads to enzymatic digestion of fat. And where all is fat present in the body? That is fat necrosis. It is seen in breast, abdomen, buttocks. It is seen in breast, abdomen, buttocks, thighs, and mesentery. Wherever fat is present in the body, so it is seen in breast, abdomen, buttocks, thighs, and mesentery, wherever fat is present. ठीक है, मान लिया. Agreed. Fat necrosis, but it is also associated with calcifications. It is also associated with calcifications due to saponification of fat. 11th, 12th class chemistry, saponification of fat. Saponification of fat in turn leading to calcifications seen in breast, abdomen, thighs, and mesentery. Fair enough. Now, my main point of concern is fat necrosis of the breast. Very, very important. Answer bache. Seen in females, of course. Young female, old female. Normally in this question, the guys are right. So, fat necrosis of the breast. Who has more fatty tissue? Young female or old female? And then guys tell me, ki, sir, we are so nice and decent, we've never had a girlfriend. It is more common in old females. More common in old females. But a young female, the breast is firm. The breast is firm. I have no idea what we mean by old breast or young breast. No double meanings. Old female. So, young female, the breast is firm. It has more fibrocollagenous tissue versus an older female who has a softer sagging breast because of more fatty tissue. Agreed. Who has a softer breast? Young female, old female? Old female, because there is more fatty tissue, so her breast is softer. Young female, the breast is firm. So if there is calcification in old female, it will be palpable in nature. It will be palpable. So you tell me, an old female comes to the OPD with palpable lesion in her breast. Diagnosis? Leg pulling, we don't have to delete answers. I mean, come on. This much leg pulling is allowed and we'll remember the content by leg pulls only. So old female comes to the OPD with a palpable lesion in her breast. Diagnosis? Can I say, don't worry Mataji, go back home, you have fat necrosis? Of course not. It is a differential diagnosis of carcinoma breast. Fat necrosis of the breast, it is a DD, differential diagnosis of carcinoma breast. So now there are two questions very commonly asked. Screening test of choice, and investigation of choice. There are two questions, screening test of choice for fat necrosis and investigation of choice for breast lesions. Answer bache. Let us first start with screening test of choice. The patient came to OPD for routine screening, or even a 40-year female who does not have a lump came to the OPD for routine screening. What is the screening test of choice? Ultrasound, self-examination, clinical examination, mammography. Screening test of choice, mammography. Agreed? Where we look for microcalcifications. You will do it in OMR. Microcalcifications is indicative of malignancy. Macrocalcifications are benign. What is the investigation of choice for breast lesion? An old female came to you with a breast lump. Which is the next investigation of choice? FNAC. Fine needle aspiration cytology. FNAC. I will not do a biopsy because biopsy of the breast is very painful. FNAC, just seeing few cells will tell me. FNAC bache stands for fine needle aspiration cytology. Just having a look at few cells will tell me whether it is benign or malignant in nature. So investigation of choice being FNAC. This was fat necrosis. So before we go further, which all patterns of necrosis have we studied? We had a look at coagulative, liquefactive, caseous necrosis, gangrene, and fat necrosis. And lastly and the most important, which is this gets us to fibrinoid necrosis. This gets us This gets us to the most aggressive pattern of necrosis, that is fibrinoid necrosis. You need to remember the diseases associated. This is the most aggressive pattern. पूछा जाता है. All these diseases will be covered in medicine. Which are the diseases with fibrinoid necrosis? Benign hypertension or malignant hypertension? Which is more aggressive in nature? Malignant hypertension. Malignant hypertension. Next, it is associated with rheumatic heart disease, RHD. RHD. Graft rejection. We'll study it in immunity. I took the graft, my body rejected it. Graft rejection. It is of 3 types: hyperacute, acute, chronic. Which is the most aggressive type of graft rejection? Hyperacute, acute, chronic. Hyperacute, occurring within minutes. So graft rejection, hyperacute type. Graft rejection, hyperacute type. Next, I'll wait for your answer on this. Suppose you have a history of a 28-year female presenting to OPD with malar rash, butterfly-like rash and photosensitivity. Butterfly-like rash is rash on the cheeks and bridge of the nose. Butterfly-like rash and photosensitivity, that is itching and blisters on exposure to sunlight. Diagnosis, SLE. SLE. We'll do it in immunity. Systemic lupus erythematosus. SLE. SLE, that is systemic lupus erythematosus. And lastly, it is associated with which vasculitis? PAN. Polyarthritis nodosa. It is associated with PAN, that is polyarthritis nodosa. You will study it in CVS in medicine that PAN has 2 phases, acute and chronic. Which is the more aggressive phase of PAN? Acute phase. Which acute phase? It is always more aggressive. Chronic is the long-term maintenance phase. So fibrinoid necrosis, it is seen in PAN, acute phase. So these are the diseases associated with fibrinoid necrosis. These are the diseases associated. And before we wrap up our first session, let us have a look at the images associated. Starting with the first image. Diagnosis. Organ. This looks like kidney or spleen. Organ is kidney or spleen, showing the presence of a well-defined wedge-shaped infarct. What is the problem that is taking place here? There is thrombus formation at the apex of the infarct. This was the blood vessel which is supplying this particular area which underwent thrombosis or embolism, leading to coagulative necrosis. This is what coagulative necrosis looks like. Well-defined wedge-shaped infarct, coagulative. Versus, I need not even ask you this image. This is brain showing which necrosis occurs in the brain. Liquefactive necrosis. Brain associated with liquefactive. I'm sure you know this. Next, necrosis, which it is very simple, straightforward. Next, lungs, showing the presence of cheesy white material, that is caseous necrosis. Please remember, seen in TB. And other than TB, it is also associated with fungal infections, histoplasmosis. Caseous necrosis. Next is organ. Mesentery. This is what mesentery looks like. This is fat. This is mesentery. Many students sometimes make it as breast, but will not make it breast till the time I don't see nipple and areola. This is fat which is spread out in a flat manner. This looks like mesentery. It is also associated with calcifications. All these are the calcifications due to saponification of fat. That is fat necrosis. And lastly, and the most important image, have a look at this. The minute I see this, I'm comfortable with the fact that it is a luminal structure with RBCs in the lumen. It's a blood vessel. The vessel wall is disintegrated. Disintegration of vessel wall with fibrin-like material. The vessel wall is broken. It is disintegrated with fibrin-like material. That is fibrinoid necrosis. First class. So, this takes care of cellular adaptations, that is hypertrophy, hyperplasia, metaplasia, and atrophy. If the cell is not able to adapt, it in turn leads to cell injury, which can be reversible and irreversible. We had a look at the biochemical mechanisms of cell injury, followed by microscopic features of reversible and irreversible cell injury. Irreversible cell injury occurred by two patterns, necrosis and apoptosis. We had a look at necrosis. Everybody, no exceptions, everybody, please give me a thumbs up if all of you are comfortable with all the points that we covered till now. Everybody, firstly. And secondly, I know we had a good first session. No doubt about this. We'll always keep all our sessions as about 1 hour 45 minutes, and then we'll have a slightly longer break at this point. So munch on something. Acha, what time do you guys normally have dinner? How many of you have in mess? Because I'm asking you this because I'm planning to wrap up the class around 9:30, 9:40. Can we do that? Yeah, do we have mess around 9? Ikba, please tell me this. Because I'm a foodie. I mean, I love 2-3 things in life. Food is one of them. Yes, Nimesh, yes, which this is fibrinoid. So let's have a 10-15 minute break at this point. We'll do the same thing every day. 7:15 first break, 7:15 to 7:30. So please munch on something. Munch on something, and then we'll go for our second session. 7:30 to about 8:30. Have a small 5-minute break, and then 8:40 to 9:40. मिताली को तो लाइफ में कोई जल्दी नहीं है, बाकी लोग ठीक है, चल जाएगा, 9:40 तक चल जाएगा. हाँ, चेंज 15 मिनट्स बचे, 15 मिनट्स. 7:30 we meet at 7:30. The link will be on the app, so we'll be stopping this link at this. Done, bache, done. So thank you, and take care. See you at 7:30.